On this episode of WarDocs, we're joined by Army Colonel Dr. Kent DeZee, the Director of Graduate Medical Education for the Defense Health Agency. Dr. DeZee discusses the intricacies of graduate medical education within the military, including the evolution of military GME programs, the residency match process, and the unique aspects of training military physicians. He addresses common concerns about deployment and training opportunities during residency, the roles of general medical officers, and how medical students can enhance their competitiveness for GME applications. Dr. DeZee emphasizes the importance of leadership and clinical experience in shaping future military medical professionals. For further information about the military health system, Dr. DeZee and our previous guests, visit our website at wardocspodcast.com. Be sure to follow WarDocs on your preferred podcast platform and subscribe to our WarDocs YouTube channel. I'm your host, Dr. Doug Soderdahl, retired Army urologist.
Welcome to WarDocs, the military medicine podcast. This show brings you a first-hand, behind-the-scenes look into the mission, unique opportunities, and deployed experiences of the entire military healthcare team. From state-of-the-art hospitals in the United States to the most austere environments across the globe, WarDocs has you covered.
Today, we're privileged to welcome Defense Health Agency Director of Graduate Medical Education, Army Colonel, Internal Medicine Physician, Dr. Kent DeZee to WarDocs. Kent, it's good to see you. Thanks for joining us.
Thanks, Doug. Great to see you too.
So before we get started about our discussion in depth into GME, can you provide an overview of the DHA Graduate Medical Education Program and its role really in preparing military physicians for their service in the military?
Yes. So first, let's define what graduate medical education is, which we'll call GME throughout this whole conversation. So most people refer to that as residencies, internships, fellowships. It's a period of time after graduation of medical school, but before one can practice medicine independently. So, for instance, I did a 3-year internal medicine residency. So that was my graduate medical education in internal medicine. And then after I graduated, I was an internal medicine physician. You did 5 years, or probably 6 years in urology at the time. Now it's 5 years. No reason why. Yes, you had to take longer. Okay.
Yeah.
Those were the rules at the time. Um, so that's what we do. So I know in a previous podcast by WarDocs, you talk a lot about the HPSP program, and I would encourage people to watch that. So this is the period after graduation of medical school, and they come to do their internships, residencies, and fellowships in the specialty. So what the Defense Health Agency does, or DHA as we'll call it, is we provide the clinical environment where the vast majority of the training happens. So we have 25 military treatment facilities, or MTFs, around the country, from as far west as Hawaii and as far east as Walter Reed here in Washington, D.C. And then at these sites, we'll have anywhere from 1 to over 50 programs at Walter Reed. The residents will be assigned there, and then we'll do a lot of the training at the sites. You'll do your internal medicine rotations, ICU, outpatient medicine, rheumatology, et cetera, et cetera, et cetera. So that's the big picture about what the Defense Health Agency does for GME.
How long has the DHA been doing that? It used to be just up to the services, but now it's kind of combined.
Yeah, that's correct. So prior to 2017, there were Army hospitals, Air Force hospitals, and Navy hospitals, and they each did their own thing with regard to graduate medical education. It's about 2000, well, the late 90s or so, two sites, San Antonio and the National Capital Area, did some combining of the residency programs. So Army and Air Force did some combining in San Antonio, Army and Navy did some combining in the National Capital Area. But they're still Army, Navy, and Air Force hospitals. Then in 2017, the National Defense Authorization Act passed, forming the Defense Health Agency's role in administrating all the hospitals. So over the last couple of years after that, the hospitals no longer became Army, Navy, Air Force hospitals. They became Defense Health Agency hospitals. And so then the Defense Health Agency was responsible for having the clinical environments to do the training.
So you've been involved in GME, from being, involved in the program itself in medicine all the way through Army GME writ large, and now you're in the DHA GME seat. What really excites you about the future of military GME, and how do you see that evolving to meet the next generation of military physicians?
I've been in GME, well, since I guess you can say since I was a medical student, and I did my first rotation at Tripler in 1996. And then I was the chief resident for a while. Then I became an internal medicine program director, and eventually became the designated institutional official, which is the head GME person at Tripler. Which still can't believe I even did that role. When thinking back that when I was a medical student, that was just some colonel you saw here and there, but you never had anything to do with the colonel. And now I was that guy, and then the Army GME lead, and now I'm the Defense Health Agency lead, which wasn't even a position when I was a medical student. So GME and the Defense Health Agency and the services has been evolving my entire career and will continue to evolve. So I'm particularly excited about our further developments in the military unique curriculum. When we train in graduate medical education in our programs, we're really trying to get three things done. One is we want to generate clinical experts. So basically, can you pass your boards at the end of your training? And then, there's other things too, but that we also want people to do. But we can prove it with board certification exams. Two, it trained to the scope of practice in the military. So, for instance, our general surgeons burn training is an elective for civilian surgeons. It's a requirement for us because, of course, our general surgeons should be skilled in taking care of burn injuries. And then the third is acculturated into the service and the Defense Health Agency. So I'm really excited about the future for military need curriculum because as the services continue to evolve and what we anticipate having to take care of in the battlefield, then our programs will continue to evolve and ensuring we have the proper training to be ready for that.
So a lot of people listening, may be in medical school, may be familiar with the National Residency Matching Program that the civilian programs
Mhm.
do. How does the military residency match program work?
So the National Residency Match Program, or NRMP, that's a civilian, more or less equivalent of what we do. There's actually a board that the Army does. That's not really a match, but everyone calls it military match. So we'll just keep calling it a military match. So ours are earlier than the civilian match, and the reason why we do it earlier is because we want to fill all our slots, and then we're not going to be able to fill everybody because we don't have capacity for everything. So then we want to have all our positions selected so that those that do need to go to civilian match will have a couple of months in order to make that happen. We start our applications in August 31st, and then one must have one's rank list done by October 15th. Then after October 15th, we do the normal scrubbing that any organization does to be sure that everyone's got all the information they should have in there. It's in their file, not in someone else's file, and everything's all correct. And then the end of October, we do scoring. So each applicant is scored in their ability to become not only a physician in that specialty, but also a medical corps officer in that service. And then those who score highest will have preference to where they would like to go, and those who score lower will have less preference as to where they would like to match to. So then we make our preliminary list based on all that. And then the week before Thanksgiving, we actually meet for the selection board with a senior medical corps officer. Each service does their own individual board. And then all those selections will be reviewed, and the board president will be ensured it meets the Surgeon General guidance. Um, we go through all the processes to make sure it's all done fair and legit. Then we, of course, scrub the process after that. And then the second Wednesday of December, we release the results. Um, and then those results will say most commonly that someone has been selected to a position at one of our DHA facilities. And then in some cases, I mentioned it'll be selected for civilian sponsored or civilian deferred, where they will go get a position with the civilian match. And then that happens with the regular NRMP process.
So tell me a little bit more about the process itself. So they're filling out, where they want to go, what they want to do. The program directors are saying, "Hey, we like these people and we rank them and we think they're going to be good at this and that." How is that computer program, I mean, does it weigh certain things more than others? And is it a similar program to what the civilian match uses when they match their residents?
Really, the Army medical students are matched to be a computer match. Everybody else, all other positions are done via the scoring that I mentioned previously. As far as does our computer system match the NRMP? No one knows because the NRMP is proprietary, so they don't tell us how they weight choices and whatnot. So I presume it's different, although I couldn't tell you for sure. It generally favors the applicant. Tie goes to the applicant. So if you have uh, a, a 2-to-1 match, it goes to where one says you're number one on the list, the other says number two on the list. It goes to where the trainee wants to go, not what the program wants.
So you mentioned some other, most of the stuff gets matched in the military match, but there are these things where someone might get civilian deferred or civilian sponsored. How does that work? And is there a difference in the service obligation after they're trained, not in the military, but at a civilian center?
Yeah, so we have a couple different categories of this. Let me just start from the top. So we have Defense Health Agency programs where we are the sponsoring institution, such as the National Capital Consortium here at the National Capital Area. And then the training happens largely and at the National Capital Area hospitals, such as Walter Reed. Then we have ones where we are not the sponsoring institution, but we have lots of training at our own facilities. So Wright-Patterson Air Force Base and Wright State University is a model of that, where Wright State University is actually the sponsoring institution, but we have quite a number of trainees who are assigned to Wright-Patterson Air Force Base with duty at Wright State University. They fall under Wright State University's training programs. They have to follow all the Wright State University rules, but they'll do quite a number of rotations back at Wright-Patterson Air Force Base to get their military acculturation, et cetera, that I talked about previously. Then we have some enduring partnerships. So, for instance, for urology, we have an enduring partnership with Duke, where one position per year will select somebody. They will go to Duke and do their urology training, but they will not have any rotations back at a military treatment facility because it's just not close enough in order for us to be able to do that. And then lastly, we have ones where we have no relationship at all. They just go straight to the match and you match where you match, and we have no influence on the curriculum or where people might go or anything like that. So for civilian sponsored, where we pay for your salary and benefits, but you go to a civilian program. If that's at an enduring program, such as the Wright-Patterson Wright Air Force Base example or the Duke example, then it's the same as if one matched at the NCC, National Capital Consortium, to do the same thing. So those cases, it is a concurrent payback with one's other obligations. So everyone who trains in our programs has to have some type of military obligation, be that from the Health Profession Scholarship Program or HPSP, such as your previous video on that, or from the Uniformed Services University. And then there's also some from the Reserve Officer Training Corps, and then there's another small one that the Navy does as well. So once you have a military obligation, you must serve that time back. If you do the graduate medical education inside the MTF or the enduring partnerships I mentioned, then your payback is concurrent. So again, let's go back to me for an example. So I did both ROTC and HPSP, 4-year scholarship for each. So I owed 8 years after the completion of my training. My internal medicine residency was 3 years long, but I got to serve back those 3 years of obligation. Actually, it's only 2 years because the internship year doesn't count. So the 2 years obligation for GME that I had was served back concurrently with my ROTC and HPSP time. So it was 8 years after I completed residency training was my payback. Now, had I gone out to the civilian match as a civilian sponsor, they just matched with any program at all, then those 2 years would have been consecutive. And I would have done my 8 years for ROTC and HPSP plus the 2 years for internal medicine for a total of 10 years of payback. And then the last one you asked about that was civilian deferred. Yeah. So for deferred, then the military is done with you for your time in the civilian match. So you're not on any list. You are just at the match like any other student at your school. When you match at a program, that program pays your salary and benefits. The military does not. And then at the conclusion of training, you come back into the military and serve your time. So if you were an HPSP student with a 4-year obligation and you or matched to a civilian deferred, you go do your training, whatever it is, and then as soon as you're done with the training, you come back on active duty, and then you would serve 4 years for that HPSP time, and you would have no obligation for your GME time because it was deferred.
But the one thing that would be a little bit unique is that you would get some credit for rank for becoming a physician residency trained. So most likely you'd be a captain or a O3 when you started paying it back for the civilians deferred.
True.
Okay. So now in DHA, you said you've got Army, Navy, and Air Force. How do those three services differ in their GME offerings? Do people have an opportunity? Let's say I'm Army, but I really like a Navy program. Could I apply for that?
The Army, Navy, and Air Force offerings are pretty similar, actually. The specialties are nearly the same. There's like one or two that are different for residencies. So not that much different. For fellowships, it can be different. Now, the Army is the largest service and naturally is going to have more choices because we have more people, more places to cover. So we're going to have more fellowship opportunities. And the Navy and the Air Force will have less or so. So some things are pretty common. Trauma surgeons, we all three services will train some trauma surgeons every year because that's something that the military needs. But other things we don't need a whole lot of, and so they may not be offered every year. We need like 2 hepatologists in the Army. We don't need 5, we need 2. So if we have 2 hepatologists and they both have long commitments, we're probably not going to train a hepatologist for a while, so that's just not going to be a choice. And you don't know that going in until you actually would get there. So those are really hard to predict for the small, unique things that we have. There's some specialties that none of the services offer. So like med peds, it's a common question that comes up. It's a not a common one, but a lot of there's a lot of programs out there for combined medical med and peds. None of the services offer that, so that's not going to be a choice. I know this question had some more parts to it, but I've forgotten what they were at the end.
Yeah, so let's say that I'm in the Army. I have an Army obligation, but I really want to go to San Diego because I think that not that I love San Diego, but the Navy, their program is just top notch, and I want to go there. Is that a possibility for somebody who's a different service?
Largely, no. So each service will post its training plan on or about July 1st every year. And then that'll be communicated to everyone who's in the pool eligible. And that training plan will have the list of places one can apply to. So you're a urologist. Let's say you wanted to train in urology at San Diego, and it's not on the Army training plan. So that would not be a choice for you. We would not, the Army would not let you apply to that program. Now, we can make exceptions, but only for really good reasons. And the most common reason is joint domicile. So if your spouse were Navy and wanted to go to San Diego, and then you wanted to go to San Diego as a urologist, then you should talk with each spouse should both, not just the female spouse, but both about your plans and you want to stay together. So we try to keep married couples together. So for this hypothetical example, typically we would say, go ahead and interview with urology at San Diego. We'll see if you were competitive for that program. And then we would try to work it out, talking with the Navy about how we could keep the couple together at a program that both they want to go to and then the program wants to match them to. So you still have to compete competitively for it. So married couples is the most common reason why we would do that. Other reasons that it would have to be very compelling. For instance, if you had a child who has an unusual medical condition and you're halfway through the treatment of said medical condition, and it really makes a lot of sense for that your child to be at a particular place, and that happens, if you're a medical student in San Diego and you really didn't want to interrupt their treatment for that child's care, and that makes sense. We would do our best to keep that together to make it work for the family. But I mean, it has to be very compelling.
Yeah,
Um,
how about if the Army has 10 positions available in a certain residency training program, but only 9 people apply or 9 people are qualified. They have one that they're not going to fill. Does the Army say, "Hey, Air Force, Navy, we've got a spot. If you need to train this particular specialty, we can take you," and that wouldn't be a problem?
Yeah, that also happens, but that happens at the board. So that week before November, when we're doing all this, the let's say the Army doesn't have enough qualified applicants for urology, as you mentioned, it will go vacant, and the Army is not going to fill that position. So rather than let that position go fallow and produce nothing from it, if the Navy or Air Force had more qualified applicants than they had on their plan, and they had for urology, and then let's say they wanted to forego another position where they didn't have enough qualified applicants, so they wanted to use the training years that they had allotted and for urology, and everyone thought that extra urologist was good. And the Army said, "Well, yeah, I've been short a couple years. This is a bumper crop." Or the Navy said, I've been short a urologist a couple years. I could really use an extra urologist this year. Can we please train in the Army program?" That generally can work out. But as mentioned there's a lot of ifs, and those ifs only come together at the board. If you want to go to San Diego and you hope it all works out, I mean, that's the level of ifs that would need to happen in order for you to be able to train in San Diego. But there is a possibility, but it's only after each service gets theirs first.
Right.
Then they would open it up to the other services, and only if they had enough qualified applicants.
So one of the things you mentioned earlier is one of the things you're excited about. This is military unique curriculum. Can you expand a little bit more about what are those unique aspects of military GME training? You mentioned trauma surgery, operational medicine. I mean, there are some things that military physicians do that civilian physicians don't do. How is that incorporated into their training?
Well, let's take family medicine for example. So family medicine programs, they have a requirement to do inpatient. They have a requirement to do obstetrics, and a requirement to have some exposure to the intensive care unit. But there's programs out there where the full intent is to train outpatient family medicine physicians. And if that's what the state needs, great. We have no issue with that. But that's not what the services need. The services need fully trained, full scope family medicine physicians who can do everything. So we ensure that our family medicine physicians have enough inpatient experience in adult medicine to be able to take care of patients deployed on an adult inpatient ward, have ICU exposure, and a number of family medicine physicians during COVID, they were taking care of ICU patients in civilian hospitals because we got asked to support places, and some family medicine physicians did it and did it well. We also tend to have a trauma exposure. So the program at Fort Benning, they send their residents for 1 month a year up to Grady and Atlanta to do a month of trauma so that they are familiar with trauma protocols, and then they graduate, then they'll be able to take care of, participate on the trauma teams to take care of trauma patients. Our family medicine physicians also do quite a bit of sports medicine. As you might imagine, we get a number of sports injuries, so family medicine physicians certainly would be familiar with that aspect of care and be able to do that. And then the Army currently requires all of its family medicine graduates to be eligible to be credentialed and privileged in obstetrics after graduating. So we go for the full 80 deliveries that the Family Medicine ACGME, or the Accreditation Council for Graduate Medical Education, suggests for those who wish to be privileged, as opposed to the 20, which is the minimum amount. So that's an example of how we are training our residents to be able to practice in family medicine after graduation, not just be a family medicine physician. And the military need curriculum applies to all specialties. I mean, some are, by the nature of the specialty, more robust than others. You might think that allergy and immunology has nothing to do with military curriculum, but that's not true at all. we ensure that our allergists are well trained to be doing desensitizing. So you might, if we have a special forces soldier that develops a bee sting allergy and develops anaphylaxis to that, it's kind of hard to deploy a special forces soldier who might get stung by a bee and then be a liability to the rest of them. So we train our people how to deal with that and treat them so that they can be deployable. And actually, our program here at Walter Reed and the National Capital Consortium, the NIH fellows actually come to our site in order to get that experience because they don't have that experience in their own program. So they gain familiarization with that. So that happens in all specialties, and the intensity of it depends on the individual, especially.
Yeah, I think one of the things that I really loved in being part of GME program in the military, being part of the faculty, was taking our residents to medical readiness training exercises. So, in San Antonio, we would go every year to Honduras and do very complicated surgeries and give them an exposure to an austere environment. And I know that other specialties do that at most of the other sites, and that's something that I think is really exciting to as a sell for military GME because it's a great opportunity. I try to go as much as I could.
Yeah, I agree with that. I'd love for every resident to be able to do that. It's a little hard to fund and get approval for that, so not every site can do it. I mean, and I went to Palau in the Pacifics when I was at Tripler to look at rheumatic heart disease, which was very informative and very interesting to be able to see patients with the disease and see some had heart valve replacements and et cetera. So that was definitely an experience that I really enjoyed. And then, as you mentioned, Honduras is a great place for you to go to get familiar with training in places where you don't have everything, and that's another aspect of our training. And the general surgeons at many programs will say, okay, great. Now you do have a CT scanner, but that's it. How are you going to be able to take care of this patient without every possible test that you may want to order? Just so they get thinking about that on a daily basis. That you don't always get every cool thing you got in America in order to take care of patients because you won't have it when you're deployed.
I know it's been 24 years since 9/11, and those of us who were wearing the uniform back then, we're thinking about, oh my goodness, I'm in GME, our nation's going to war. Am I going to go as a resident, a third year resident? What would you say to folks who are have concerns about that? Will I get to finish my residency before I get deployed, or how does that work?
So one can be deployed as a resident to support contingency operations overseas. That is a true statement. One of our surgeons general actually did it when she was a resident several surgeon generals ago. But that's probably the last time it actually happened. And she wanted to do it for that. But the vast majority of residents will not deploy during residency. And I don't think it's happened since the year 2000. At least I don't think it's happened at least for 25 years. That being said, I mean, if America was full scale war and needed every available physician to do something and deploy, that might very well happen. You could get pulled out of residency deployed, but that would be like a Team America problem when all of America is supporting a large scale combat operation effort. Um,
Right.
that's
I mean,
pretty much it happened now. Yeah.
yeah, your fellow resident at the U is joining the Team America as well. So let's talk about some other scenarios. You match in a transitional year program, which is a 1 year program, and you're not residency trained when you're finished that, and you want to do a residency. So how do those folks, let's say, you're a transitional year intern, or you've completed a transitional year internship, or you're in the middle of another residency and say, you know what, this is not for me. I need to do something else. Or you finished another residency and say, you know what, I really want to do this. How do those folks interact with the match?
So all those folks are eligible to compete again in the match, just like medical students are. And if they've done really well in their jobs, then they actually get a little leg up, not a big leg up, but a little leg up for the other ones. So that's the short story. So the longer story is for transitional year residents. They all will be eligible to apply 3 months into their transitional year, which is just right after graduating medical school. So they'll be able to apply in the next match. Some choose to apply and some choose not to apply. They just wish to go out and be a general medical officer. So that's fine if that's what they wish to do. Um, so if you do really well in your transitional year, then you would have a slight advantage over someone who hasn't done who is a medical student who's not done a transitional year because they haven't had the opportunity yet. And I say slight advantage because, if you really struggled in medical school and let's say you failed a licensing examination and your clinical years weren't very good, and then you came to do a transition year, and then you did really well at your transitional year, you're only going to get a slight advantage over that because some of that poor performance before still carries with you. But it's certainly advantageous, of course, to do well as a transitional intern. So what I'm trying to say is that a medical student who does super well in his AOA versus a transitional year who struggled during medical school. The transitional year, no matter how well you do in a transitional year, it's not going to outcompete an AOA, Alpha Society, like one of the top graduates of medical school. That's just not going to happen from a straight standpoint, assuming everything else about the AOA graduate is good. But you do get some advantage. Okay. Um, so for those who go out and are, graduated from transitional year and have been a general medical officer, then their tours as a general medical officer, that also informs their packet. So again, if you do well at that, then you also get a little bit of an advantage from that. So you get to compete like everybody else in the match.
So what happens if a medical student isn't selected for their preferred internship? I want to do something that's super highly competitive like urology, of course. And they're not, they're not selected. What are the fallback options for that person?
So they would be matched into another program. We'll assume that this urologist only applied to urology programs, didn't indicate any other specialty that they wish to apply to. So they would be probably almost certainly would be placed in a transitional year program. Occasionally, might be placed in a preliminary surgical year program, but it depends a little bit on the service. The Army has less of those, the Navy has more of those, and the Air Force has some of those. And then they would be allowed to compete in the following year, just as mentioned. They can hopefully do some urology rotations at the beginning of their transitional year. Also, they can you can do some research at the end of your medical school year that might improve your application when you would apply again the following year. So the services are going to give you a spot, um, and be that a preliminary position, either transition year, either medicine or surgery, et cetera. And then you get to hopefully do well and compete again.
So let's say you complete a transitional year, and you get accepted for a residency. How does that residency view your transitional internship year? Do they say you got to do another internship, or hey, that counts? You can come in as the R2?
That depends on the specialty board. So for some boards like internal medicine and family medicine, many of the rotations can count towards graduation requirements for IM and FM. Not all of them. So typically, the folks who do a transition year and go over to IM internal medicine, they'll be like 1 to 3 months off on their graduation date, which is fine. For surgery, unless you did a general surgery preliminary year, transitional year doesn't count. Sorry, you're starting over. Orthopedics, same thing. The orthopedic board does not permit transition year to count for anything. Sorry, you're starting over. So basically, what happens is your transition year. We'll see your evaluations from that and the final evaluation. That goes to the new program. The new program reviews it. They talk with their clinical competency committee, who are the senior faculty members of that program. Then they'll put forth a petition to the board as to what we should count or not count, and then the board will say, this is the credit you get. And then we'll say, well, that's the credit you got. So then you're going to either train, like for internal medicine, you're going to train 2 years with us, or 2 years and a month with us, or 2 years and 3 months with us, et cetera, because everyone's going to be board eligible when they finish. We will not graduate somebody early on a time basis and then have them not board eligible. That's not happening. Yeah, so you will do the amount of training required by the specialty board.
You talked a little bit about the general medical officer tour. What exactly qualifies someone to be able to do it? And is there a different philosophy between the different services, Army, Air Force, and Navy, as far as where a GMO tour could fit in your overall GME training?
Yeah, so the Navy uses GMOs the most, Air Force and Army less so. So a general medical officer primarily will be like a unit doctor, such as a battalion surgeon in the Army, or a flight surgeon, or undersea medicine for the Navy. So generally, you complete a postgraduate year one, which is any internship. You must pass your step or level three of your licensing examination, and then get licensed by a state, an unrestricted state license. So let's assume all those things happen. Then you are eligible to be a general medical officer. So then you'll do some additional training depending on what your role is. There's a 6-week flight surgeon course for the Army, for instance, and then you would be a flight surgeon and assigned to a flight unit. The flight unit's going to have a senior flight surgeon to, be a mentor for you. So it's not like you're going to be out there on your own, and mentor you through your course. But you will be an independently practicing physician. You'll get to your new site, and then there's something called a focused practice review or evaluation, FIPI. I'm forgetting one of the P's. So your practice will be evaluated by your supervising doctor to ensure that you can deliver safe care, and then you'll be an independent practicing physician on your own. But you'll always have somebody there to help you out. And the same thing for undersea medicine. You go to the undersea medicine course. You learn about submarines, and then battalion surgeon, you go to the battalion surgeon course and learn about all the stuff that a battalion surgeon does. And then you're in there for 1, 2, or 3 years, depending on what you want to do. And there's an occasional person who really loves what they're doing and they just want to stay a GMO, and that's fine if they want to do that. And then once you complete that, then you apply to compete in for GMB again.
But that's okay for the service. If they said, "Hey, I want to be, I owe 4 years and I want to be a 4-year GMO, in some operational flight surgery thing because that's been, what I've always wanted to do," that's fine.
Yeah, you could do that. Well, if you want to do an operational flight surgeon thing, I'd encourage you to apply for aerospace medicine. We have residencies in that, and you can be fully trained. And the people who do that really love those specialties. You get certified to be a pilot. You do some cool stuff in their training program. So for that example, I'm going to plug aerospace medicine. Well, I got the opportunity. Yeah, but there's some people who choose to do that. I think most services would prefer that you come back to residency training, but it's not for everybody. And they may decide, what, for 4 years, I've served my country, I've really enjoyed it, but now I want to move on to civilian medicine. I'll just apply to the civilian match and do whatever specialty I want to do, and that's fine too. The services, we pick enough people to do what we need to do, but it's not designed for everyone to become a colonel. It's designed for some people to become captains and majors, and then choose to leave the military, and then other people to stick along for longer careers. The Navy again does more for that, and the Navy actually has a new program they started last year where there's a couple of specialties you apply, and you have this GMO tour programmed in where you do 1 year of the specialty. You go do 2 years as a GMO, and then you're already selected to come back for residency in the same specialty at the same location. So you don't have to recompete for it. So as long as you don't do something dumb during your GMO career, like get into a lot of trouble for like a professionalism problem or something like that, then the position is yours to come back to. You don't have to recompete for it. So the Navy just tried it this past year. So the first group is actually in PGY1 now. We'll see how it works out. But so far, it seems to be pretty exciting for folks. And then and just to finish that story, let's say you do 1 year as a GMO and you decide, you know what, I don't want to go back to whatever residency I started with. I want to do something else. Then you can compete for something else. You're not committed to it. That reminds me, you had previously asked about what about people who are in residency program and decide this is not for me. So this happens. Every year at some site, there's at least one person that does this, where they get 2 months into their PGY 2 year, their first year of residency after internship, and they say, you know what, I do not want to do this anymore. So you're allowed to resign from your training program. Uh, if you're licensed and you would go to compete. You'd be a general medical officer, and you can compete in the next board that you would be eligible to compete in. If you are resigning because you just if that especially isn't for you, that's generally not looked upon poorly as long as you're doing well to that point. And then people will, of course, interview when you do recompete. They'll ask you about it. It says, why didn't this work out for you? And you give them an honest answer. Um, so it's okay. It happens. For some people, we will kind of PGY2. For sometimes it makes sense for them to finish out the full year and then leave. Other times it's best is to go ahead and leave right then. That's flexible. Those are individual decisions to be made about what's best for the service and the individual and the program as to how that when the resignation happens. I will say though that once one resigns from a program and it's been approved at the local site, then that's it. There's no going back. You cannot reverse your decision. You will end training at the date that the contract, that the agreement says you're going to agree, or earlier if you want to move it up, and you will be a general medical officer. And then if you want to compete, you'll have to recompete again in another selection board. So we don't let people be wishy-washy about it. Resigning is resigning, and your resignation date can be in the future, but once you commit to resigning, then that's it. You're committed to that.
So when you're in a DHA GME program, you are on active duty, you're wearing the uniform, you're subject to UCMJ, but that military service is also concerned about your military education. And so, I'll speak from the Army. We have the basic officers course, we have captain's career course, intermediate learning. How does that work with residency training, and which one takes priority, and can you do both?
For the officer basic course, we'll just use a general term. The services each have their own term for that. So we're generally going to make everyone do that before they start residency programs. So for some people who weren't able to get that done during medical school, it'll actually delay start of residency, and that's okay. The residency directors get over it. It's not looked upon poorly if that's the way it worked out for the individual trainee. Sometimes we'll have people do a 1 year training and then have them take a break from their clinical training to do the officer basic course and then come back to training. And on rare occasions, we'll actually have people go to the officer basic course at the end of training. Other training happens during residency, like C4, which is a week-long training where you get ATLS, which is Advanced Trauma Life Support certified, and you do some field training with some basic stuff about how to take care of people in the field and whatnot. So that happens during the PGY 1 year in general. Occasionally that doesn't work out, and people do that in their last year of training before they graduate. USIS graduates do that as part of medical school, so they don't do that training during that. And then other aspects of military life, those things happen either lectures or experiences during residency as appropriate for the particular subject matter. So the idea is we graduate people who are ready to practice as a medical corps officer when they graduate, and we don't have to retrain them and stuff once they get to their new duty station.
So we have a lot of medical students that listen to the program and are looking for some advice of what they should be doing. And I think what they just heard is that getting basic done while you're in medical school is a good idea. Are there other things that really could help enhance their ability to optimize what they want to do? Clinical rotations, research, leadership roles. How do they best compete and impress that board when they're looking at their packet?
The board members are looking for are you going to be able to be a successful physician in this specialty? And B, are you going to be a good medical corps officer? So the bulk of it, frankly, is are you going to be a good physician in this specialty? So that's judged by your clinical experiences that you've had both in medical school at your own school and at your annual training time and your third, and usually more likely your fourth year of medical school when you actually do an away rotation at a MTF with a residency program. So that's going to be evaluated very heavily. That's probably the most important thing is if you want to be an orthopedic surgeon, you should do an orthopedic surgery rotation at one of the MTFs during your fourth year. And just be well prepared for that experience. If you are a student during your fourth year and you haven't done the basics to be familiar with the language and the acronyms of that specialty, then you're not going to be as competitive as other ones. So do well in medical school is also the tip. If you continually struggle and finish at the bottom of your class of all of your experiences, then you're not going to be as competitive as one who does well during medical school. So that's steps one, two, and three is convince people that you want to be a clinician in that specialty by your actions and things you do. The other things that help is, we're looking to generate medical corps officers. So we have to look at what you've done during medical school and how does this project to you being a leader. So if you are the class president, certainly that's pretty easy to extrapolate that you've had some leadership experience. So that's going to help your application. If you're active in your school's military student chapter, if you've had like another leadership role, a vice president, a membership director, whatever, those are also viewed favorably. But if you go through medical school and you do nothing extra for anything for the school, it doesn't have to be a military role that you're being a leadership role in. But if you don't, if you're not, I guess we had no taking services back in the day. I don't know that they do that anymore with that. But if you didn't do that, you didn't do any community service or whatever, then your application will look empty for are you a future leader for this, and then you will not score as well as somebody who does have those leadership experiences. Research also helps. It's probably not as important as leadership, and it also depends a bit upon the specialty. But certainly, research is really factored into are you going to be a good clinician and a good academic leader in the specialty. So, I mean, that helps a little bit, but it's not required to have research experience.
So a lot of people ask me about the research, and one of the questions they have is, should I try and do research in the area of what I'm interested in going into? So let's say I'm doing ortho, I want to do ortho. Should I do some kind of orthopedic surgery research, or is basic science fine, and does it matter?
And that really depends upon the specialty, and it's probably a little bit mercurial as to what the faculty there like. I would say that any research is better than no research. If you can do it in the specialty of interest, great. But any research that you do, is you can talk about that intelligently. That helps. If you do basic science research and you show that you're knowledgeable and excited about it when you're doing an interview and you can talk with your folks about it, then the program can extrapolate that you have some research skills and you can apply that to research in the specialty after you start the training program. So yeah, research in the specialty helpful. Yeah, maybe a little bit, but it's not the end all be all of everything.
You may want to dial back your knowledge of like the Krebs cycle when you're talking to the program directors, and you're like, okay, I don't understand a
Well, but
word you're
but if you
saying.
can if you can
Yeah, that's
explain your
true.
complicated research and
Yeah,
have everyone understand it, that's really impressive.
that's
Lots of
true.
people cannot do that, and if you can do that, you will impress people. I will say that most assuredly, and
Yeah, I
apparently
guess I
you'll impress Dr. Soderall. That's for sure. If you can explain.
Well, but that's the point I'm making is that I've talked to folks who applied for residency and they can explain it, and that turns off the program. But so if you're doing some kind of research, you need to understand it and make sure that other people can kind of figure out what it's all about, and that is a skill, and that's something that is recognized by the programs. You did mention, USU's has this, program where during medical school you do some of these operational things. You learn ATLS and maybe you don't do C4 when you're an intern. What other opportunities are different between HPSP students and USU students?
Well, USU students, they have a leadership curriculum that's integrated through all 4 years of medical school. HPSP, it's just going to be dependent on what your school has. The services do give you leadership training during your officer basic course, but it's not like integrated as a long-term program curriculum that USU has. USU, they have like 600 to 700 hours of additional experience and like how ballistics affects injuries affects humans and things like that. And working in teams that you're not going to get an HPSP. So I mean, the graduates of USU are going to be more experienced in areas of leadership training as well as military specific injuries and working in teams in in the military environment. That's part of C4 during the internship year is to help HPSP students make up from that the USU students already had. So I mean, there's certainly HPSP students can certainly stay active in military stuff, but you gotta kind of do it. It's not going to be if you're USU, you're going to have to do it because that's the curriculum. But I mean, you can do things like listening to podcasts, such as the one you're listening to right now, and the other WarDocs podcasts out there. USU is actually putting together a monthly curriculum where you can actually meet virtually, especially directors, and they'll have an hour or two, like a Teams or a Zoom meeting where you can meet and talk with them about things that the programs are doing. Each service, they have, as I mentioned, go to your basic course and then do your other training as you go through.
Yeah, I would definitely put a plug in for that military medical communities. That really is a monthly opportunity, and they generally pick a specialty. So hey, I think the next one is aerospace medicine, flight medicine, and they just did orthopedic surgery. Get involved in that. The WarDocs has an ambassador program that we basically, have folks who are medical students, pre-meds, that we want to create a community. So, everybody gets to meet the team before they're actually, on the team and deployed as a team. And I think that's a good thing for military medicine. One of the things that I was impressed with is that, the DHA is doing a pretty good job of putting this information about GME on their website. So tell me about how you get there and what is your website good for and why should folks go to it?
So the website has a very detailed description of each program and what they do and where they are and who can apply for them. So we put a lot of work into making this website really valuable for our primary consumer, which are medical students. Other people use them as well. Those currently on active duty. We've invited their recruiters to be able to look through there and see where our programs are. So when they're talking to potential medical students who've not get committed to the Army, so they can see what's out there for their program. But you really get a good flavor for how the program works, what kind of additional experiences you might be able to get at that. Each institution page has some details about the local environment, and so I'd really encourage you to go through that site, whatever specialty that you're interested in. It's pretty easy to do. Right on the front page, you just say, "I'm Army Internal Medicine." You can leave the site blank, and then you click it and it returns all the programs for Army Internal Medicine. You can go through each one individually and then see what piques your interest. You can write down questions that you may want to have. Each one has a links to where you might apply to go to rotations. Also have to get a shout out to Michelle Valdez, who was the institution coordinator at San Antonio, who was really the primary driver who got all the DHA website started, and also Michael Simons from San Diego. He's a similar role there. He also had a lot of role, as well as Ms. Naima Grove and Miss Leanna Dulaney from my office, who did quite a bit of work to make this DHA Jimmy website app. So we're really excited about it. It really shares what people can expect to be doing, and it really helps communicate our what we do to others, so that when I'm talking about we're not just training family medicine physicians, we're training medical corps officers. You can go to the website and really see how each program approaches that.
And I don't need a DoD ID
Nope,
card. I'm not signing up for 4 years of obligation if I click on a link. It's all
nope.
good
It's all right
information.
there. It's all just information. It's publicly available. You're not committing yourself to anything. So I just would encourage you to go through it. Yeah, and I think when you read through those, you really see the tone of excitement that the program directors and the faculty have when training residents. And we're really motivated to do it. I brought my prop here. well, I have to bring my prop because I can't go anyplace without it. I had surgery at Walter Reed last month, and it's as planned. I'm still non-weight bearing, so um, I'm really interested that we have good training programs, having just undergone surgery. And a USU fourth year medical student put in my IV, and she did a great job. If you're watching, you know who you are. We're not just excited. We're excited about it because we really want to, develop the next generation of medical corps officers. But there's a selfish interest in it too, that you want the people you train to be able to take good care of you and your family. And of course, I mean, you get up in the morning because you want to train people who are going to take care of America's heroes. America sends their sons and daughters to join the military and then go out in harm's way, and they deserve the best medical care. And our program directors and our faculty are absolutely dedicated to making sure that we give people the best training. So when they go out there and they're practicing on their own, and wherever it is that may be, at another medical center or another place around the world, that they're prepared to do it and give our people the best care that we can deliver.
Yeah, I think that's a huge point that is underestimated sometimes is, GME and the civilian sector, you're training those residents, you want them to be good, but it's pretty unlikely that they're going to actually be taking care of you, down the line. But, I've had plenty of opportunities to have care from folks who've, been rotating through my service, or I've been deployed and I see folks that are taking care of our, America's sons and daughters in the most austere locations doing a great job. And that's something that, those trainers really take seriously. So for those who are interested in training in the system, that's a big deal. Is, we've got, your trainers have ownership of what they want, because it's a little selfish, but you're taking care of the team and you're part of the team.
Exactly.
So we've talked a lot about, GME, and I've asked a lot of questions, and I'm sure that you in your role now get some questions and that are frequently asked. Is there anything that you think that we didn't cover that's important for folks to know, or any particular advice that you give our listeners, especially those who are currently in medical school that are obligated, either USU's HPSB, maybe a service academy, maybe ROTC? What kind of advice or questions that you could answer?
I think one question that comes up is, will the Army, Navy, Air Force, DHA make me do something? With the exception of the transitional year, if you didn't get your primary specialty, the answer to that is no. If you really want to be in, and we talked a lot about orthopedic surgery. So if you really want to be an orthopedic surgeon, you compete for that. You don't match. You're a transitional year resident, and then you at the end of transitional year, you compete again for orthopedic surgery, and you don't get it. And you become a general medical officer. And then 2 years go by, and it's like, it's time to compete again. Would you? Unfortunately, weren't successful with orthopedic surgery twice in a row. Do you want to try to compete for that again, or do you want to try a different specialty? It's an option. It's not a requirement. If this hypothetical person wanted to try for orthopedic surgeon for the third time, they could. But we're not going to make them do a different specialty because that just doesn't work. You can't make someone do a residency program, and it's just too hard to do. You have to be interested and dedicated to what you're doing. And if you're just not dedicated to that specialty, it just doesn't happen. You're not going to be a good doctor. So we don't do that. With the only exception is we will make you do a PGY 1 year, which is the internship, in order to be able to get licensed to be a physician. So that's a question that comes up, and I just want to
And,
put that out
and
there. Yeah.
and the other side of that is that, let's say you don't get trained in what you want to train in the military. That doesn't necessarily mean that you don't have an obligation. You still have obligated services. So whether that's as a general medical officer or in a different residency program, it doesn't mean, hey, I'm not smart enough to be a urologist, and therefore you have to cancel my commitment.
Uh, yeah, I don't think anyone's ever said that, but the obvious
I
answer
I
is
just said
no.
that.
No, you will serve back your obligation, and if you don't compete successfully, you will serve back your obligation as a general medical officer. Yes.
Well, we've been speaking with Dr. Kent DeZee on WarDocs podcast. I've known Kent for a long time, and I can think of no better person to be in this position, kind of overseeing the graduate medical education in the military. Kent, thanks for sharing your experiences, your insights about GME, And thank you for your service. And thank you for, taking some time during convalescent leave after having surgery to do an important thing, which is answer some questions and really promote what the opportunities are in military GME.
Well, thanks, Doug, and well, thank you for your service that you did for 30 years, and glad to do it, and thanks for giving me the opportunity to speak to you and your listeners today.
Thank you for listening to WarDocs. We sure hope you enjoyed it. WarDocs is a nonprofit organization supported by donations from listeners like you. Please follow and subscribe to our show on whatever platform you consume your podcasts, and rate and review this episode, and share the show with your contacts on social media. Find out more information about our show, our guests, and how to become a member of Team WarDocs on WarDocsPodcast.com. Thank you for your support. If you like war stories and medical drama, WarDocs has you covered. Spread the word.